Thank you for the introduction and for this forum to present our data. This has been a great day so far, so we'll continue. I don't have anything to disclose about this presentation. So we'll start with ERAS. Everybody, I'm sure, is very familiar with the ERAS protocol, how it's been greatly implemented in the last couple of decades of surgery with all the research that's gone into it. And we know all of the pre-op, intra-op, and post-op interventions that we've done that help our patients do better after surgery. For instance, some of the opiate-sparing pain regimens, early ambulation, changes in how we allow patients to eat and drink before surgery, all those things and come together to help our patients do better. And so I'd like to start with this paper really quick from Dr. Varian about how they looked at programs that had done ERAS implementation and how well their patients had done and shown. So through here, we can see that the programs that had implemented the ERAS with different levels of adherence and how much better their patients have done. So we can see every category, there's a significant difference in decreased length of stay, readmission rates, other complications, leaks, ileus, things of that nature. So this has kind of prompted, we're here to try to decrease our patient stay and all the way to the point of, can this be done in a less than 24-hour ambulatory period? So Dr. Sadat has this paper about a NS-QIP review of these patients where they did a 23-hour, so overnight stay after a laparoscopic colectomy, and they found that none of these patients had an increased risk of readmission. This was followed by another single institution report of ambulatory colectomy in 157 patients that was done over in France. And their ambulatory rate was just under or just over 30%, which is impressive. And this was one of the first demonstrations that it was safe and effective to be able to do an true ambulatory colectomy. So that leads to our presentation. What were we trying to seek out to prove? So we wanted to identify how much are we actually using this early discharge, with all the ERAS protocols, and are these patients being discharged earlier over time or not? And then within that group, we were going to look at the true ambulatory post-op day 0 discharge, those patients, and see, were they at an increased risk of readmission. So we performed a retrospective review of the NS-QIP database from 2012 to 2017 of patients that underwent a laparoscopic right hemicolectomy. Just under 20,000 patients met criteria, with just under 4,000 being included in what we labeled as the early discharge, which is post-op day 0 to 2, and then late discharges, post-op day 3 or more. And then, as you can see, 114 patients met the true ambulatory post-op day 0 discharge. So we compared those patients to each other. First, we compared the early discharge to late discharge, and then within the early discharge group, the ambulatory versus the rest of the early discharge group. And we wanted to see, are we using this early discharge more over time? And then is there any impact of the discharge date itself on whether or not these patients had an increased readmission rate? Here's our first graph that shows over time that, yes, early discharge is being utilized more. And we'll point out down at the top dotted line how the post-op day 2 within the early discharge, so patients discharged 2 days after surgery, going up, increasing almost threefold in the study period. Post-op day 1 discharge, so like that first paper I commented on, the 23-hour colectomy, again, going up over time, not as impressive as the post-op day 2, but yes, we are starting to utilize that more as well. Post-op day 0, they do exist, but not being utilized more over time. So when we looked at these patients, looking at the delayed discharge versus the early discharge, some notable things stood out, although not as surprising to us. So these patients in the delayed group were older. They had a higher burden of disease, so higher prevalence of COPD, CHF, diabetes, renal disease, and the ASA class, just the general marker of how more disease they had. And then also the early discharge patients, these operations were shorter. They were performed more for polyps rather than higher disease burden, like cancer or inflammatory bowel disease, for the indication of their colectomy. So when we compare and look at the risk factors for readmission in the early versus delayed group, the odds ratio, here we have the early discharge, including 1, so no increased impact there for the early discharge. Within the early discharge group, when we look at ambulatory versus the remainder of the early discharge, again, we see some of the same similarities in that the ASA class was generally lower in the ambulatory group with, again, a little shorter OR times, more straightforward cases, not as many for cancer or inflammatory bowel disease. But interestingly, in terms of patient characteristics, they were very similar to each other. And then again, when we look at the odds ratio, is having an early discharge a risk factor for being readmitted? And again, we see that no, it is not. So when postoperatively comparing these groups again, early versus delayed, the delayed groups, not surprisingly, had increased risk of reoperation, complications, mortality as well. And then in the ambulatory versus the remainder of the early discharge group, there weren't any differences in reoperation, complications, readmissions. This study, limited mainly by the retrospective nature, it was a cohort from a group of patients from 2012 to 2017. In the NSQIP database, we don't know the specific protocols that were used for every institution in terms of, fluid management, things of that nature. And then there's an overall small number of ambulatory cases. So in conclusion, we did see that the early discharge did increase over the study period. So we are using it more, but the true ambulatory is pretty rare. The POD0 ambulatory discharge is safe and feasible in these data that we've been able to analyze. But I do think further studies will have to be, I think, aimed more towards protocols as well for patient selection and to see who's really this is safe for. So that's all I have, and thank you so much for this opportunity.
Thanks, Dr. Human, for an outstanding study and a very nice presentation. Before we open this for discussion, we have a primary discussant, Max Trudeau from University of Pennsylvania. Max, do you have some prepared comments?
Yes, I do. Thank you for the introduction, Dr. House. Congratulations, Dr. Hewittman, on a great presentation. I really enjoyed it. I have 2 questions. First, in regards to same-day discharge, do you ever believe that we'll be able to progress to a point where we have more of an empirical way to select patients for same-day discharge? Or is this always going to be something that is reserved to patients who have a certain gestalt, are robust, and the surgeon's comfortability? My second follow-up question to that is, how many surgeons do you think are really going to be comfortable with same-day discharge? And if you actually implemented this into a protocol, do you expect non-adherence to be high? Thank you.
So to answer your first question, I think, like a lot of things that are new, it's going to be still driven almost on a case-by-case basis. So a lot of these previous studies that were showing that it was safe and feasible were in a very vigorous patient selection and highly selected. And so, like I was saying a second ago about how if we're going to use this in the future, again, maybe develop a more strict implementation of a protocol that's more universal to really see if this is feasible. And then to answer your second question of, I mean, how many people do we think are actually going to do this is hard to say. I know, I mean, we're all surgeons in training or surgeons, and we can get stuck in our ways a lot. And I think it's going to take an open mind and being able to have good data to support us to be able to change our practice in terms of being able to, you know, say maybe this is safe and we can try to discharge our patients earlier.
Great. Other comments?
Yeah, no, I think this is a great topic, Rich, and it was excellently presented, and there were great questions by Max as well. I think, and it gets right to the heart of it, right? Because I think what we're seeing is this is the unicorn patient. So I'll just tell you that we've started a protocol here at UAB for outpatient colectomy. And what we found is we don't have unicorns here in Alabama. Our enrollment into this protocol has been so incredibly slow that it's really hard. So I think implementing this is going to be really tricky. And the other part is that of my 7 colorectal partners, or the 7 colorectal surgeons here, only 3 of us are interested in participating because it's a little bit too out there on the fringe for people to do. So I think that's really the heart of the problem. So I guess the one thing that limits people's interest in participating, I think, Rich, is the idea of failure to rescue, right? So if the patient's in the hospital and we've got outstanding residents like yourself taking care of them, patient gets sick, some complication happens, we survive the patient because of this tremendous care around them. What happens when they're at home? Any evidence that failure to rescue at home is higher? Have you ever read anything about that?
I have not, but I can imagine that would be a very big concern. And in the age of medicine that we are in, with doing more virtual, you know, we're able to connect with our patients a little bit more through things like, you know, Zoom and other virtual patient encounters. I think that could be one way to counteract a failure to rescue of something, especially with how we serve patients in areas where they're not 5 minutes from the hospital. It's a little more rural, and I think maybe that's a way to help prevent that.
Great. Lastly, Rick, in your data set, I was curious, in the same day discharges after right colectomy, were these patients centralized to just a few centers? You would have had access to those data in your NISQIP project, or did you find that they were kind of spread among many institutions and centers?
To be honest, I'm not sure. I would have to go back and look at the data to see the distribution of the patients, but I'm not quite sure.
That will help you get to Dr. Kennedy's point of being that I think that this does need to be protocolized. We do know that patient selection is going to be most important, but how do we monitor patients in an outpatient setting after having major abdominal surgery in the end of the day? Whether it's a wellness platform on a smartphone, of whether it's daily visits or check-ins with advanced practice providers. But I do feel that for this to move safely forward and to become more widely used, it will require specific and strict protocols to be in place.